Okay, today we're going to cover musculoskeletal disorders. Real quick, anatomy and physiology review. As you can see here on this first slide, the layers of bone, the outside layer, we must remember bone is a living part of our body. So there is a blood supply as well as nerve supply to the bone. So there is such thing as bone pain. The outside layer contains just that, the neurovascular bed and supply, and then the inner layers, you have the hard um, compact bone on the outside and the inner layers of spongy bone, which encases the bone marrow. And if you remember from week 1, bone marrow is where the blood cells are made, red and white blood cells. And issues affecting the bone marrow will cause different anemias and immunosuppression due to poor supply of blood cells. Sorry. Now moving right along. Again, anatomy and physiology review. The creation, resorption, and remodeling of bone metabolism. You need to understand that when we're born, the skeleton is primarily made of cartilage. Cartilage is a little more flexible and bendable than bone, and over time, that cartilage hardens, or we have ossification, which is the hardening of that cartilage. Osteoblasts are the cells which formulate bone material and lay down the bone and harden bone. Osteoclasts are responsible for breaking down either damaged or old bone cells so that we can make room for new bone to be formed. And thus, that is metabolism, right? Our body is constantly making adjustments, getting rid of the old, creating new to replace it. Just like red blood cells go through hemolysis, during their lifespan. All cells have a lifespan, and then they die and new cells are replaced. In addition, when we have an insult or injury, a fracture, penetrating injury, what have you, and even autoimmune attack or whatever, our body is going to try to adjust and make new cells. And this is a process called bone remodeling. Resorption is that digestion of the old cells. Osteoclasts are responsible for resorption, and remodeling is the process of creating new bone. And that is that bone metabolism. We go through this constant cycle of resorption and remodeling. So when we're looking at the musculoskeletal system, diagnostic procedures include x-rays. I'm pretty sure by this point we're all familiar with x-rays and what they do, and the need to protect childbearing women, reproductive organs, yada, yada, yada. The DEXA scan is something new that we haven't talked about before. The DEXA scan is also known as your bone density scan. This should be done as a baseline for women in their 40s because osteoporosis is most common in women. During the test, it's like an x-ray. It's done at the doctor's office. It's non-invasive. But patients need to be reminded to wear loose clothing, no jewelry, and we want them to stop any supplementation for their bones 48 hours prior, so that we can get a good accurate read on their actual bone density. CT, MRI, we've already discussed. Ultrasounds can be useful, most specifically in children, infants, and small children. We don't like to expose them to unnecessary radiation. So ultrasound is actually what we use to diagnose like hip dysplasias and things like that. Infants, they tend to order ultrasound and x-rays and CTs. Those things are reserved more for emergency situations. Ultrasound is usually the preferred method of scanning. Nuclear scans are performed in nuclear medicine, like a triple phase bone scan or nuke med scan. This is what they call these things. This is most commonly used when we're trying to diagnose metastasis to the bone or primary bone cancer. A radioisotope is injected a few hours prior to the scan, and then the scan is performed. And of course, anytime we're injecting dye, we need to encourage the patient to increase their PO fluid intake so they can flush that dye out of their system. EMG and nerve conduction studies. These are just like a EKG is looking at the electrical conductivity of the heart, and EEG is looking at the electrical conductivity of the brain. And an EMG or electromyography or electromyogram is looking at the electrical conductivity across the nerves or across the muscles. And then nerve conduction is looking at that same thing, nerve signal. This is useful, especially in diagnosing all those neurological disorders we talked about last week: Guillain-Barré, myasthenia gravis, multiple sclerosis, Lou Gehrig's disease. It is also used to diagnose carpal tunnel. Anytime a patient is complaining of weakness or paresthesia, for example, with patients with lumbar spine issues and now they're having numbness or weakness in their legs, we do these exams for. So it's called an EMG with NCV. So electromyography is the muscle study, and then with the nerve conduction study on top of it. So they do attach these wires, electrodes, whatever, and then they produce a painful stimulus using a needle. So it's not a pleasant exam, but for many of these people, they're already having paresthesia and can't feel the needle. So anyways, next, another invasive procedure is an arthroscopy. Arthroscopy is actually performed in OR, just like in a laparoscopic procedure. Any other laparoscopic procedure, it's performed usually under general or heavy sedation. But they're going in with this scope, just like you see here in the picture, and able to actually visualize the internal structures of the joint. It is usually used for the knee and the shoulder joints only. It should not be performed, obviously, if a patient already has an active infection in the joint, because that can lead to septic joint, osteomyelitis, and serious complications. Obviously, it's a surgery. Informed consent is required. Any of these scopes, like even if a patient has a cholecystectomy, a laparoscopic cholecystectomy, laparoscopic appendectomy, obviously, if I'm going in with the camera, I need to be able to visualize what I'm trying to see. So there is a lot of water or saline, whatever, being flushed through while this is going on. So after any of those procedures, the patient tends to have a lot of swelling because of the injection of fluid. So with the knee, it is expected for them to have significant swelling after the procedure. With the appendectomy or cholecystectomy, the patient also tends to have a bloated, distended abdomen because of that introduction of fluid. So post-procedure for the arthroscopy, the patient is going to need to apply ice, RICE techniques, which means rest, ice, compression, and elevation. And then they're going to be referred to PT for rehabilitation after this procedure. With an arthroscopy, they can perform other, repairs and things. They can repair ligaments. They can shave back, osteophytes, which are bone spurs, with patients with arthritis. There's many other things that can be done arthroscopically. So let's talk about disorder. Osteoarthritis, it is inflammation of one or more joints, and it is due to a degeneration, destruction of cartilage. Cartilage, remember, is that soft, flexible, cushiony tissue. It protects the bones and allows for smooth movement and reduces friction as the bones, move through either wear and tear through sports or occupational related injuries. The cartilage, what's basically happening is the cartilage is being destroyed much quicker than it can be replaced. So risk factors, again, repetitive use, occupational, sports, those kind of things. Age, obviously, as we get older, that process of degeneration naturally occurs, and it's going to occur faster than we're able to reproduce cells. So aging, women are going to be more at risk. Anyone with metabolic disease, such as diabetes, issues with their thyroid, different types of metabolic disease, obesity, and of course, smoking put you at risk for anything. They're going to have chronic pain and stiffness. Pain is usually aggravated with activity and relieved with rest, versus with rheumatoid arthritis that lasts longer than an hour, and it tends to improve throughout the day with movement, versus osteoarthritis, it worsens throughout the day with the use of these joints that are already inflamed, and it is worse usually at the end of the day, and it usually before it gets severe. When it's severe, it's just hurting all the time, but it's usually relieved with rest, RICE techniques, that kind of stuff. With osteoarthritis, you may palpate crepitus, that grinding sensation. If you put your hand on the patient's knee and have them bend it out and extend and flex the knee, you will feel grinding or crepitus if they have significant arthritis. Herbert's nodes, you need to know those. Those are at the distal interphalangeal joints, versus Bouchard's nodes are at the proximal interphalangeal joints. So know the difference between those. Joint effusions may occur. These are more likely to occur with rheumatoid arthritis, but definitely can occur with osteoarthritis. And over time, you have muscular atrophy. So pain management is a big thing. You could use ice, could use heat, whatever works for the patient. RICE techniques, like I said, encouraging exercise. They may be referred to physical therapy. Treatments include Tylenol is the first line treatment, okay? Pain management. Tylenol, this is where Tylenol is useful in treatment of osteoarthritis. If Tylenol is ineffective, you could use some topical analgesics, such as a lidocaine patch or diclofenac topical gel. These are especially for patients who are at risk for GI upset, patients with peptic ulcer disease. Topical analgesics may be a safer choice for them. There are supplements for your proctor exam and for your exam 5. You do need to know about glucosamine. So you need to read up on that. One thing about glucosamine, it does help decrease inflammation in the joints. However, it also comes with some major adverse effects, including increased risk for bleeding. So you need to read up on these meds. Corticosteroids, most specifically injected intra-articularly, which means into the joint space. Intra-articular is in the joint space. Corticosteroid injections will help decrease inflammation of those nerves. When that arthritis becomes severe, patients may even require a replacement of the joint, and that's your arthroplasty. It can be performed in just about any joint, but of course, knees and hips are probably the most common. Some people do end up getting a shoulder or elbow, but most common, the one you're really going to see all the time, is knees and hips. It can usually it's due to severe degenerative disease. Remember, DJD, degenerative joint disease, and OA, osteoarthritis, are the exact same thing. Okay, 2 different names, same disorder. The big thing about arthroplasty, I mean, again, don't focus so much on intra-procedure, but more so what your nursing considerations are. For one, infection and preventing infection is huge. It is so easy for these patients to go septic with this new foreign body. So that is why pre-op screening and the chlorhexidine bath and pre-op preparation is pivotal. They will not even perform this surgery if the patient has a urinary tract infection, and that's why the UA is collected. Obviously, this is a big procedure, especially the hips, a very bloody procedure. So coagulation times, PT, INR, and PTT are pivotal. We cannot perform this procedure if the patient, and CBC really, if the patient is already at risk for anemia or bleeding. During hips, commonly they will even perform what's called an autologous blood transfusion. That is, they are collecting the blood the patient has lost and saving it and filtering it so that they can transfuse it right back into the patient's body. Other complications include VTE, which is venous thromboembolism, or DVT formation. So VTE prophylaxis is a common practice after getting a new hip or a new knee. These patients, depend on the surgeon, are going to be on some sort of VTE prophylaxis. TED hose or compression stockings are to be used. SCDs, sequential compression devices, those little boots we put on the people's ankles and feet, those need to be used. And of course, we need to be monitoring CMS, which I'll talk about in a minute. Circulation, motion, sensation. This is your neurovascular assessment, and it needs to be assessed frequently. Osteoporosis. Osteoporosis is a metabolic disorder in that, remember, metabolism is that constant creating of cells and resorption of cells. That is that bone metabolism. So, yeah. So what happens is osteoclast cells, the resorption cells, are resorbing old bone tissue at a higher rate than osteoblasts are able to create and lay down new bone tissue. So what happens is you get these weak sponge-like bones with osteoporosis. Risk factors, this is one of those diseases that actually Caucasians are at the highest risk for. Women and thin, lean people are at high risk. So this is unique compared to other disorders. Caucasian, thin, lean women, men with low testosterone, and then of course, low calcium and vitamin D. Calcium, vitamin D, and phosphorus all play an important role in bone production. So low levels of calcium, low levels of phosphorus, and low levels of vitamin D all impact bone metabolism. These drinks and beverages, including phosphorus containing carbonated beverages, soda, caffeine, excessive alcohol use, all put patients at risk. Certain medications, including levothyroxine, thyroid hormones, diuretics such as hydrochlorothiazide, which causes you to excrete calcium, corticosteroids, and anticonvulsants like Dilantin, phenytoin, also works on the patient's calcium, lowers the patient's calcium levels and the action of calcium. And yes, and malabsorption, of course, if they're not getting the nutrients they need. What they're going to look like, they're going to have a reduced height related to this kyphosis of the spine. Kyphosis is that humpback versus lordosis is that archback. So kyphosis of the spine is going to lead to reduced height. They're likely going to have chronic back pain and be, of course, at high risk for fractures. The diagnosis is made with that DEXA scan. The DEXA scan is used to diagnose osteoporosis, and it can also be seen on other scans, x-rays, CT, MRI, all that. So nursing considerations, you need to know your vitamin D and calcium rich foods, your dairy products, milk, spinach, these things, you need to know these things. They may even consider supplements. Weight-bearing activities such as walking is important. Low impact weight-bearing activities. Also, exercise to strengthen the core. Anybody with back issues, back pain, kyphosis, anything like that, they need to strengthen those abdominal core muscles to help support the spine. And of course, avoiding heavy lifting and extenuating activities. Also, having low protein will also lead to poor bone health. Fall precautions. Obviously, if these people have osteoporosis, they're going to be at high risk for fractures. So you need to protect the patient, teach them about fall precautions, how to wear appropriate shoes, removing throw rugs. You guys should already know about fall precautions at this point. Treatment options. Obviously, physical therapy is always an option. Orthotics, such as this right here. They have different braces, TLSO brace, thoracolumbar brace, thoracolumbar, sacral brace, whatever. But those are some non-invasive measures. Then invasive, You have arthroplasty, where a patient can actually get an artificial vertebrae and joint place, but more commonly, you're going to see a kyphoplasty or vertebroplasty, where they are injecting just cement into usually a compression fracture in the spine. So of course, this is a less, not minimally invasive, I guess you would say, minimally invasive surgical procedure, in that it's usually just done under fluoroscopy or, interventional radiology. A catheter is placed. They're probably under general or moderate sedation, may not be put all the way to sleep. And this procedure is performed. Again, they're forcing a needle into this area. So you always want to be on the lookout for a pneumothorax or some other unintended injury. And like all post-op procedures, monitoring for pain, swelling, bleeding, infection, yada, yada, yada. As far as medication, calcitonin is a thyroid hormone, different than levothyroxine, which is like synthetic free T4. Calcitonin is used for the treatment of osteoporosis. It works to limit the breakdown of bone. And therefore, because of that, when bone is broken down or resorption occurs, calcium is released into the extracellular fluid. So it increases it decreases our calcium levels if we're decreasing the rate of resorption. So it decreases our calcium level if we're decreasing the rate of resorption. Whereas the action of osteoclast, a normal part of bone metabolism, is resorption. So when bone is broken down, calcium is released into the bloodstream. Therefore, we give calcitonin to stop the breakdown of bone, stop that release of calcium, and it will treat hypercalcemia. So if a patient is on calcitonin, we need to monitor their calcium levels closely. And this is only used for treatment. It is not used for prevention. When we talk about it later, calcitonin is also used to treat phantom pain. Now, the rest of these medications are used for prevention and treatment. Raloxifene decreases osteoclast activity, and therefore prevents and treats osteoporosis. However, it works on increasing our absorption of estrogen. So anything that increases estrogen places patients at risk for DVT, and also can cause liver issues. So raloxifene and actual estrogen supplements, we need to monitor those patients for signs of DVT or any type of clot, PE, whatever. Biphosphonates, alendronate, another drug you need to know for your proctored exam as well as exam 5. It works by decreasing the number and action of osteoclasts, thus inhibiting bone resorption. It is used for prevention and treatment of osteoporosis. Again, it may cause hypocalcemia, so you must monitor, because how biphosphonates work, they work to increase phosphorus. However, remember that inverted relationship between phosphorus and calcium. This could cause low calcium. There is also some significant risks associated with the use of these drugs, including esophagitis and esophageal ulcers, and also necrosis of the jawbone. So osteonecrosis of the jawbone and esophageal ulcers are two serious complications of this drug. And then I already said estrogen, it increases risk for female cancers and DVTs. All right, moving right along, sprains and strains. This is speaking more to our muscular system. But remember, musculoskeletal, they go hand in hand. A strain involves the muscle or tendon. Remember, tendon, as you see here in the picture, tendon binds muscle to bone. So a strain can occur in the tendon or muscle versus a sprain occurs in the ligament. Ligaments attach bone to bone, okay? These are often caused by falls, heavy lifting, overuse, but basically what's happening is it can cause instability of that joint. It can cause severe pain. And there are different degrees. So with mild, they may just have mild pain. They may have some mild bruising, swelling due to the mild bleeding happening under, from this tissue, injured tissue. Moderate will involve actual partial tearing of the muscle, and a third degree involves ruptured muscle. So depending upon the degree of, and it's the same pretty much for a ligament, depending upon the degree of injury will determine the treatment. So management can include application of heat. It can include application of cold, exercises, stretching, definitely NSAIDs and muscle relaxants are definitely first line therapy. And surgical repair is going to be needed if there is a complete rupture of a muscle, tendon, whatever. Rice techniques, again, for the sprains, rest, ice compression, and elevation. Immobilization may be necessary, and arthroscopic surgery can be used to fix a ligament injury. So back pain is a lot of times related to strains and sprains. Of course, it can also be related to osteoarthritis, osteoporosis, wear and tear on those discs in between the vertebrae. Back pain is most prevalent from age 30 to 60. It can occur in any race, any sex. You're going to be at higher risk based off your occupation, heavy lifting, that kind of stuff. Again, smoking, so expected findings would be a dull or sharp, whatever, back pain. They may be stiff, decreased range of motion. Pain may be aggravated depending on what level the injury is at or the inflammation. They may have pain that's aggravated with different movements, muscle spasming, sciatic nerve compression can cause pain, burning pain in the buttock. And there is an exam where you have the patient lay down and or sit up and lift the leg. A straight leg lift will elicit pain for patients with different nerve compression. Now, most alarming is going to be this right here. Anyone who's got signs and symptoms of sepsis, anyone who has a complete loss of function, numbness, saddle paresthesia is numbness of the groin. bowel incontinence, bladder incontinence. All of these are going to indicate my patient may have a spinal cord injury versus just bone and joint pain. And we talked about spinal cord injury in the neurological chapters. Back pain management. Again, a lot of this is ergonomics and knowing proper body mechanics, stretching, knowing proper positioning and sitting, avoiding prolonged standing, wearing properly fitted shoes, sitting in a recliner, elevating the legs, even laying on your back with the knees bent up will relieve a lot of pressure off of the lower back. Meds. Now, in this circumstance, Tylenol is usually not helpful. Again, NSAIDs and muscle relaxants are the first line treatment for back pain. NSAIDs and muscle relaxants. May also resort to mild opiates and again, the topical creams, lidocaine patches, those kind of things. I have never used this med, ziconotide, so I wouldn't get too hung up on this particular medicine. Now, complementary therapy, again, just different pain management things that have been talked about before, the TENS unit or an intrathecal pump. Again, these are things, I need to touch up, I need to fix this slide, sheesh. But anyway, we know about pain management. Moving right along, let's talk about fractures. There are many different types of fractures, and you don't necessarily need to memorize every single type of fracture and how to diagnose it, but you need to have some general ideas of what's happening. One, there's closed and open or compound. Closed, obviously there's no break in the skin. Open, now we have a break in the skin and there's bone tissue exposed. You need to know how to manage compound fractures for your proctored exam. And that would include applying a sterile dressing, that kind of stuff. So you do need to review that for the proctor, not necessarily exam 5. Compression fractures is also the same as impacted here. These are the ones you typically see in the vertebrae. Displaced versus non-displaced means, is it aligned or is it completely unaligned or dislocated, basically? And if it is displaced, so if this is non-displaced because it's well aligned, non-displaced. But if one was going this way and one was going that way, that would be a displaced fracture. Pathologic means it's disease related. So could be from my dialysis patient who has hypocalcemia related to end-stage renal disease. It could be a pathologic fracture if it is related to cancer. Assessments include, obviously, the most important, and I'm going to talk about it next, is neurovascular assessment. Most important assessment in patients with fractures and musculoskeletal trauma and injury. Neurovascular assessment, pivotal. You need to know what it is. You need to know every component of the neurovascular assessment. You need to know that for this exam. You need to know it for your proctor. You need to know it for your final. You need to know that for NCLEX. Now, initial assessment of the fracture, obviously you're looking to see, is there a deformity? If it's usually a hip or shoulder, it may be internally rotated or externally rotated, depending on where the fracture is. And it may be one leg may be shorter than the other. So one leg may be shorter, with the leg rolled inward. And then, of course, with an open fracture, you're going to see visible bone. Crepitus is that grating, like I told you, muscle spasms. You may have edema and swelling, ecchymosis again, or subcutaneous emphysema, which could be a late finding. Emergency care, obviously, ABCs. Assess vital signs and neurological status. Again, neurovascular assessment. Make sure there's good pulses, distal to the injury. Elevate the limb for the swelling. Assess for if someone's having trauma, obviously we're going to assess if they have internal bleeding, if they have a fractured rib, make sure they don't have a pneumothorax or a hemothorax, things like that. Cover open wounds with a sterile dressing. Obviously, if they fractured their arm and they have on a wristwatch, I'm going to remove that. I'm going to remove anything that could potentially cause more harm as their arm continues to swell. Stabilize the injury, splint the area, and include joints above and below the area, the site of injury. And then, of course, reduction or traction for those fractures, like I said, that are not aligned and they are displaced. So there's different types of casts. Plaster casts can take up to 72 hours to dry completely versus fiberglass, synthetic fiberglass, which is most commonly used, usually dries within 20-30 minutes. Okay, so a plaster can take up to 3 days to dry versus synthetic can be dried within 30 minutes. Obviously, skin needs to be assessed. We need to maintain skin integrity. It should be clean and dry prior to applying anything. Bony prominences need to be padded and protected to prevent breakdown. Elevation, ice. You're not going to apply heat to enhance swelling. If you apply heat, like we talked with exam 4, it's going to cause vasodilation and thus increase swelling. So ice is going to be your best friend. If they have this plaster cast, then we need to turn and reposition them every 2 hours so that the dry air circulates and the cast dries faster. Also, if we keep them sitting in just one position, for example, with this hip spica cast, if we keep them in one position, it's going to cause deformity due to the pressure of them sitting in that one position. We do not use hair dryers or heat lamps to dry it. And you may need to support the extremity with a sling or propped up on a pillow. Traction. Traction is using a pulling force to maintain alignment. This is for those displaced fractures to help maintain alignment. The bone cannot heal if it's malaligned, or rather we don't want it to heal. They're going to have lots of complications. So there is a straight or running traction. This is also known as skin traction. It is a counter traction caused by the client's body. And it's basically this right here up top, that Buck's traction. Bryant's traction is another one. Bryant and Buck are the straight skin traction. These patients cannot move. Movement is going to alter the traction provided. So they can shift their weight and everything, but there's really no reason for them to be moving all around. Versus with balance suspension, the traction uses slings or splints, and the body can move without altering the traction. For example, a patient with a halo traction is actually able to ambulate while they wear that big old halo traction. The screws are inserted in the bone. And so with that, you're going to be at high risk for introducing infection to the bone. So you must teach the patient about pin care. So here's another device known as an external fixator. So this is another reason for pins. Sometimes we have rods and things surgically implanted. Other times we may need an external fixation. So there are a rod inside my body is called an internal fixation versus this here is an external fixation. It's outside my body. So you may see patients, especially when they fall and break a hip, the common procedure is a ORIF, open reduction. Open means I made an incision. Reduction means I aligned or reduced that malalignment. Reduction. And then internal fixation. I reduced it and I have placed a rod in there to keep it well aligned. So open reduction, internal fixation, common procedure you see. If a patient has an external fixator, or if they're in skeletal traction, the main thing we are concerned about is infection on top of alignment. So alignment, first and foremost, we need to align and immobilize that bone and then prevent infection. Pin care is usually performed every shift and at least twice a day. And you are cleansing and drying the pins, keeping them clean and dry. We typically leave it open to air, or as you see here, they just put some dry dressings to allow cushion. You're using a cotton applicator like a Q-tip, and you designate one Q-tip to each pin site. Signs and symptoms that they have a pin infection could be localized, such as increased swelling, erythema, purulent drainage, could cause loosening of the pins, could cause tenting of the skin at the pin site. So skin is rising up the pin site. They could also have systemic symptoms such as fever, nausea, vomiting, diarrhea, those kind of things. So it's very important we maintain good pin care and teach the patients as well. So nursing considerations. Again, the neurovascular assessment, CMS, circulation, motion, sensation. You want to make sure they have a capillary refill less than 3 seconds. The two extremities are the same color. They're warm temperature. They're able to wiggle their toes or wiggle their fingers. There is motion. And they can feel you touching their most distal point, their fingers, whatever, depending on where this cast is, or splint or what have you. Neurovascular assessment initially should be performed at least every hour because we do not want these patients to end up with compartment syndrome, which I'll talk about in a minute. Yeah, so with the neurovascular assessment, circulation, motion, sensation, we're going to also teach them to maintain neurovascular integrity, Rice techniques, elevating the extremity, again, ice. Remember, heat promotes vasodilation. So when their arm is in a cast, heat is not going to be our friend because it will promote swelling. Encourage foods to promote healing of the fractures. Never place foreign objects. You shouldn't be scratching inside the cast with any foreign objects. itching inside the cast. You can relieve itching by blowing cold air into the cast, but do not insert anything in there. For the children with the spica cast, they're going to, you're going to need to protect the perineal area and protect that cast from getting wet or soiled with urine or feces. And any cast, they need to waterproof it before taking a shower, whether that's wrapping it in plastic, whatever. So now let's talk about potential complications of fractures. So again, that neurovascular assessment is pivotal because a serious complication of fractures and musculoskeletal injuries is compartment syndrome. Remember that third spacing we talked about, where fluid fills in the interstitial spaces in between tissues. Fluid is going, in this picture here, in between the muscles where it's not supposed to be. It causes increased pressure. It also compresses blood vessels and it decreases perfusion. So it can be caused by external or internal sources. External sources such as a cast, improperly fitted tight cast, or constrictive bulky dressings, too tight, and then not allowing room for swelling. If the patient has an injury, we have to allow some room for swelling and movement, but also ensure that the cast or dressing is not too loose either. And then of course, an injury could cause bleeding within the muscle compartment or fluid collection, such as heart failure or something. So when you're doing an assessment, you're checking for the 5 P's: pain, paralysis, paresthesia, pallor, and pulselessness. You're going to have pain and swelling unrelieved with elevation or pain medication. Early signs are going to be numbness, tingling, pain, pallor, versus late sign is going to be loss of function, paralysis, weakness, cyanosis, pulselessness. Muscles may be hard and swollen due to the edema in that interstitial space. And then, of course, neuromuscular damage is going to begin to occur due to decreased perfusion. Ischemia can occur. Treatment may include a fasciotomy. I'll show you a picture on the next screen. Fasciotomy is just an incision made into the fascia, that fibrous lining of the muscles. They make a fasciotomy through the skin and the fascia to allow release of that pressure. They may, of course, leave that wound open. So that's going to require sterile packing to allow it to heal. It may even require a skin graft later down the road. A fasciotomy, when you learn about burns next semester, is the same as an escherotomy, where because that eschar from burns creates this tight leather-like skin, and the same thing happens, compartment syndrome. So again, neurovascular assessment, you need to be familiar with this. This is one of your select all that apply questions on your exam 5. It is also, you are going to be tested on a neurovascular assessment on your proctored exams. And this is just pivotal to know in your nursing practice period. Another option could be just to make that incision in the cast versus the actual skin. Here's pictures of exactly what I just mentioned, that bivalve, that cut in the cast done with a circular saw such as this, or they could actually go to surgery or and have these fasciotomy incisions made in the skin and in the fascia, that fibrous protective covering on the muscles. All right, another severe complication, especially of long bone fractures, is a fatty emboli, fatty embolism. This creates fat globules that will enter circulation. This again for patients with long bone or pelvic fractures. So this is why immobilization of long bone fractures are so important. Patients with displaced long bone fracture may require bed rest and minimal manipulation until that leg is immobilized with surgery or what have you, especially like a femur fracture, hip fracture. Those patients need to be on bed rest until it's immobilized to reduce the risk of a fatty embolus traveling and basically causing obstruction of blood flow to the lungs, like a pulmonary embolism. Signs and symptoms are hypoxemia. They're going to be restless, confused, agitated. So that's your neurological abnormalities. They're probably going to be tachycardic and tachypnic. And a late finding in fatty embolism is a petechial rash. Treatment, you're going to apply high flow oxygen. They may end up needing mechanical ventilation, and high dose corticosteroids can be used to treat cerebral edema caused by the fatty emboli. Sorry. Last complication of fractures, and not only just fractures, wounds, is osteomyelitis, which is infection within the bone. It can be acute or chronic. It is infection of the bone marrow, and it is difficult to treat and eradicate. It usually ends up in amputation. So this is a serious condition. This is why it is important to treat infected wounds and treat diabetic wounds in particular, because we do not want the infection to travel to the bone and bone marrow. It can, like I said, lead to loss, necrosis, and loss of the limb. Risk factors you see here, obviously open fractures, penetrating wounds, that's going to lead to, direct entry point for bacteria. Diabetes is going to increase your risk for every infection. Why? Because bacteria feeds off of sugar. Diabetics have higher glucose in their system, so they are at risk for poor healing and infection, wound infections, and osteomyelitis. Obviously, those on hemodialysis are already have calcium and phosphorus imbalances. So their bones are weaker and more spongy, easier to become infected. IV drug use, again, is just like penetrating wounds. You're injecting, self-injecting. It's very easy to get all kinds of infections. And then anything that's going to lead to poor blood supply, avascular necrosis, which is a common complication of sickle cell disease. And again, hyperparathyroidism, which is going to cause disturbances in calcium and phosphorus again. These patients are likely going to show systemic symptoms when it is acute. However, chronic osteomyelitis, they may no longer have fever and, nausea, vomiting. They may have adjusted to this, but they will have the swelling and, usually a necrotic appearance of the wound. This is confirmed with bone biopsy and culture. It can also be seen, as you can see, on the x-ray. And it requires long-term IV antibiotics. Patients are going to need a central line, PICC line, whatever. This is likely caused by MRSA, but there are other, nasty infections, Pseudomonas and other infections that can also cause these infections in the bone. Hyperbaric chamber is one treatment option. It's putting them in a high oxygen concentrated chamber to assist with healing. And then of course, surgery, like I said, amputations. So other musculoskeletal disorders, like I just mentioned, we're going to talk about amputation, scoliosis, clubfoot, and developmental dysplasia of the hip. These three are more pediatric disorders, and then carpal tunnel, which is really a peripheral nervous and musculoskeletal disorder. Surgical amputation. Again, this could be due to osteomyelitis, where that limb ends up needing to be amputated. It is surgically done due to deformity at birth, to remove maybe a cancerous tumor, or if it is, life over limb, and keeping that limb is going to cause loss of life for whatever reason, or it's necrotic. But whatever the case may be, the main thing you're probably going to be tested on is going to be management post-operatively. Studies that they do beforehand is just like the things we talked about in peripheral circulation, looking at circulation to the extremity. But here are the things that you need to be considerate of: pain management, psychosocial support, because it is a lot, especially if you're losing. It's one thing even to lose a finger, people have a hard time with that, let alone losing a whole leg or arm. A lot of self-esteem issues. Referrals to PT and OT to assist with use of prosthesis, and getting back to a normal life after loss of a limb, and phantom pain. Traumatic amputation, obviously this is different than the planned surgical amputation. We're talking about trauma that has now caused you to lose a finger, a hand, whatever. In the event of a traumatic amputation, you are going to apply gauze or cloth and apply pressure to prevent hemorrhage. Instruct the patient to elevate their extremity, obviously above the heart, to slow down the blood flow. You're going to wrap that extremity, the severed extremity, so the foot in this case, wrap that extremity with dry gauze and place it in a sealed plastic bag to protect it. And then you're going to put that sealed bag in ice water. You don't want to submerge the finger, the extremity, whatever, in ice water, because that water is going to cause damage to the skin. But you're going to put it in a bag first. Phantom pain is most common with surgical amputation. It is due to severing of the nerves. It is more than just psychological. It is, remember, pain is what the patient says it is. So it's not just psychological. These people actually feel pain in their limb that's no longer there. So this foot that's been amputated, and they're still feeling that sharp pain. Treatments include calcitonin, the same medication we discussed with treatment of osteoporosis. Beta blocker, such as propranolol, And these anti-epileptic drugs, gabapentin, also known as Neurontin, pregabalin, known as Lyrica, these are commonly used. They're less likely used, even though they're anticonvulsants, they're less likely used for seizures and more likely used for nerve pain. You do need to know these drugs, side effects of gabapentin and specifically. Antispasmodics or muscle relaxants, same thing. Those are commonly used. And then alternative therapies. You can instruct the patient to press down against the bed with this limb. It's going to apply pressure to those nerve endings and also give them a reminder that that limb is no longer there. Aftercare, post-surgical care. You need to know about the figure 8 wrapping method. It's to prevent restriction of blood flow and improve swelling and edema. You do not wrap, it's not going to be just a circular wrap around the limb. You don't want to do that. That can impede the blood flow and cause poor healing and damage to the stump. So there's this special figure 8 method that is used to wrap the stump. You want to prevent contractions, common contracture like an above knee amputation. Too much prolonged sitting can lead to a hip flexion contracture where their hip is actually contracted and that leg is stuck out. So you want to encourage them to change positions, spend some time laying prone or on their belly. Obviously monitor for signs of infection. Again, you want the extremities sometimes position it in a dependent position. Let the leg dangle to allow circulation to that stump, blood flow and oxygen. If they're on antibiotics or they require dressing changes, you're going to take care of that. You're going to document what you see. Avoid, again, prolonged sitting, stand up straight, and yep, and like I said, okay, so covered all that. All right, scoliosis. This is a lateral, side to side curvature of the spine. It's abnormal. It's like an S shape, scoliosis. Common in adolescent females. But we screen all boys and girls starting in pre-adolescent years, like around age 11. You're going to see asymmetry in the ribs, flanks. You see one shoulder's down lower than the other. You see the asymmetry of the ribs. Some are more prominent than others. You're going to test the child by having them bend over and touch their toes. You should be able to see this curvature when they bend over or see the asymmetry of their torso. And sometimes when it is really severe, you see the asymmetry even when they're just standing upright or sitting upright. And again, signs and symptoms will be also improperly fitted clothing. You can see this, of course, on any imaging. So treatment is going to involve bracing. They will have to wear braces, a back brace, 23 hours a day to help correct the curve and slow the progress. This can be embarrassing for these young girls, especially teens. So encouraging them to socialize. And then, of course, there's also surgical fusion with internal fixation or rods. They're going to be initially admitted to the ICU. Again, it is a bloody procedure. They will likely receive auto means self, like an autobiography is a book you wrote about yourself. Autologous transfusions is we collect your blood during surgery and re-administer it to you. So they may receive autologous transfusions. They're going to need consent, either from the patient or the parent, depending on the age. They're probably going to be on a PCA pump. Remember, that is patient controlled only. After surgery, we're going to log roll the patient. Initially, we are not going to be manipulating the spine. Log roll them in bed, and we're going to perform a range of motion exercises on their limbs without, manipulating the spine too much. They're obviously going to, oh, I don't even know why I didn't finish this, but they're obviously going to be referred to physical therapy, possibly occupational therapy, teaching, incentive spirometry, any surgery in the upper body. You want to encourage use of incentive spirometry every hour. They need to cough and deep breathe. Because they are going to be at risk for atelectasis and pneumonia after surgery. So remember this with every condition. It is used to help treat pneumonia and atelectasis and also prevent the two after surgery. Incentive spirometry. This is inhaling. They are inspiring incentive spirometer versus the peak flow meter. They are blowing out, and that is a test for asthma. Incentive spirometry every hour. Again, adolescents, while they're hospitalized, you want to encourage socialization with their friends. And even while they're going through this process with the bracing, socialization is important. Remember, they're in that identity versus isolation chapter of their psychosocial development. Clubfoot, here you go. This is a congenital deformity. It's usually genetic, usually occurs in the presence of other various congenital syndromes. And there's many ways you could have the foot bending inward, outward, toes pointing upward, or have toes pointing downward where they're walking on their tippy toes. These are different issues that the feet, the abnormal curvature in the feet. But basically, casting is the main treatment for this. They basically stretch and form the foot or ankle into the proper alignment or whatever, and they go through a series of casting. So again, they're going to be wearing casts. You're going to be monitoring neurovascular assessments. You're going to be monitoring for signs and symptoms of infection, skin breakdown, that kind of stuff. CMS, circulation, motion, sensation, and monitoring skin, and all that, okay? Developmental dysplasia of the hip. This again involves a couple different ways that the patient is born with a dislocated hip, basically. Here's the risk factors here. Usually occurs in new firstborn babies, vaginal delivery breech position, and especially larger babies who have a hard time fitting, when they are delivered vaginally. So asymmetry and unequal number of skin folds, like you see here in this picture, is a hallmark sign of hip dysplasia. Also, the shortened femur, that's with any hip dislocation or fracture. So shortening of the femur. Ortolani and Barlow tests are performed by the doctor, the pediatrician, and basically they bend the knees up and out, and they can feel the hip sliding back in and out of place, but that is performed by the doctor, but they're called Ortolani and Barlow. And again, here's symptoms in a child. Again, because it's usually diagnosed in infants, ultrasound is usually the primary exam to diagnose that, and then of course x-ray. Here are those tests, Ortolani and Barlow, just showing you what it is. You've probably, if you have kids, if you've been around a pediatrician's office, you've probably seen this test performed. The doctor does them to every baby, pushing those thighs, basically applying pressure and pushing them upward, and then bending the knees outward, feeling that reduction, basically the hip popping back into place, and then dislocation and relocation of the hip. So yeah, and you see it here in the images. Dislocation when they bend the knee back in, and when they bring it out, they're able to relocate it back into place. Other treatments, so here's that spica cast, the casting, maintaining alignment of the hip. So they can't bear weight while they're wearing this. They may be in traction, okay, pulling the legs up. So they're going to need to be turned and repositioned. Again, keep this area clean and dry. This is called Bryant's traction when they're pulling the legs up. Remember, this is skin traction. There's no walking or anything in a spica cast or with this kind of traction. For the small infants, they also have this harness to hold the hip in alignment. Finally, last couple slides, carpal tunnel. Carpal tunnel is compression of this median nerve. It occurs in the wrist, usually due to a thickened synovium. This fibrous tissue builds up here. Usually it's occupational related to repetitive use, usually of computers and handheld devices like cell phones and tablets. So it's becoming more and more common, obviously. It causes numbness and it can be painful, paresthesia, usually of these first three fingers, the thumb and these two, and maybe sometimes the ring finger is involved, but it's usually these three. It's pain and numbness, and the ironic thing is it's often the worst at bedtime. So worse at bedtime, and upon waking up in the morning, they'll say they feel like they have to shake their hands out, like their hands are just dead asleep, pins and needles, what have you. Tunnel's sign involves tapping on the median nerve, which will cause twitching and may cause that paresthesia. Tapping on that median nerve will cause them to feel this numbness. And there's also Phelan's sign, having them flex the hands, the wrists at 90 degrees against each other. And it's going to also cause paresthesia. So Tunnel's sign is tapping, Tunnel, tap, will cause paresthesia of these fingers here. And Phelan's test is having them flex their hands together. It will cause this paresthesia, numbness, tingling, pins and needles sensation in these three fingers. Medications include anti-inflammatories, NSAIDs. Again, corticosteroid injection by an orthopedic, specially trained practitioner provider is an option to decrease inflammation around that median nerve and also hopefully thin out some of that fibrous tissue. But usually when patients are getting those corticosteroid injections, they typically only last for months, maybe a year tops. Conservative therapy also includes wearing splints or hand braces, especially at night. You may initially tell them to wear them to bed at night. That's when the symptoms are the worst. Or they may wear them all day long and at night. And then, of course, yoga, exercise are some other options. There is surgical decompression, where they just kind of shave back that fibrous tissue and release the median nerve. Surgical decompression, they're decompressing it. Most commonly, it is done open. An incision is made. When they do it endoscopically, it causes longer recovery time. It's better to just open the wrist up. And it's not that difficult of a procedure. They just open it up, shave back that fibrous tissue, try to avoid the median nerve, and stitch it back up. You're gonna obviously teach them they're gonna be at risk for swelling, compartment syndrome, those kind of things. You want them to elevate the hand to reduce swelling. When it is okay, when they're cleared by the doctor, they will begin physical therapy, using things like a stretch, or what do you call a stress ball. You have to perform neurovascular assessments. This is the most important assessment of the musculoskeletal system, the neurovascular assessment. And then managing the pain. Heavy lifting, yada, yada, yada. You can read this and we're done. All right, so let me know if you have any questions. Good luck. And there are more musculoskeletal resources uploaded in the Moodle.